I would first like to acknowledge the Kaurna people, the original custodians of the Adelaide Plains and the land on which the University of Adelaide's campuses at North Terrace, Waite, Theberton and Roseworthy are built. Welcome everyone to this very special forum, which is the latest in the University's Research Tuesday series. My name is Richard Russell. I'm the Pro-Vice-Chancellor for Research Operations at the University. Just 2 weeks ago, the University of Adelaide launched its new Reconciliation Statement during Reconciliation Week. The University is very strongly committed to reconciliation right across the whole university community, and we genuinely believe that it's important for all our communities to take this journey together and in harmony. Tonight, our Research Tuesday Forum deals with a topic which we believe is critical to the future of Indigenous communities. We're talking about health, what's happening and why it's happening, and what we can do about it together, not just in isolation. We are privileged this evening to have 3 speakers on our forum panel, each of them bringing a wealth of experience and expertise on Indigenous health. Associate Professor Lisa Jamieson is Director of the Indigenous Oral Health Unit within the Australian Research Centre for Population Oral Health in the University of Adelaide School of Dentistry. Dr. Janet Kelly is a Research Fellow in the University of Adelaide School of Nursing, and Dr. Carla Canuto is a Postdoctoral Research Fellow at the South Australian Health and Medical Research Institute, working in a centre known as CREATE, that is to say the NHMRC Centre for Research Excellence in Aboriginal Chronic Disease Knowledge Translation and Exchange. Our facilitator tonight is Mr. Elwyn Chong, Director of the Yatacha Paruna Indigenous Health Unit in the University School of Population Health. I'm going to introduce you now to Elwyn and let him look after you for the remainder of the evening. Shall we welcome our panel?
Thanks, Rick, and welcome to the forum tonight. It's a significant tonight because we're talking about health-related issues around Aboriginal communities, and the 3 speakers bring a diverse range of topics. But before we get started, one of the things that the university has been trying to embed in its practice is doing an acknowledgement of country, or at least, a welcome to country, or at least an acknowledgement of country. That is something that is being embedded in a lot of the faculties now and going right across the university wide. So without any further ado, I'd like to introduce you to Rob Taylor, who will be doing Welcome to Country for us.
Nyankina meana, namane, mani nabudni ganayata, nyari Robert Kadi Karamil Taylor, nyarindiri naranga kumagana meana, mani nyadul tampati gana meana. Kumanadlu Pani Yatanga and Berendi. Tabandadlu Bukyana, Borkana, Kumagana Miana Eyalara. Mukabandadlu Tapi. Mukabandadlu Mudki. Mukabandadlu Munaicha. Mukabandadlu Yancha Miana. Nayakandalya, Jungbandalya, Nachalya. Ladies and gentlemen, did you get all that? Some, a little bit. Well, here in our beautiful country, we don't just have one Aboriginal language, we have over 250 different Aboriginal languages. The language that I just spoke then was the language of, I come from 3 main Aboriginal groups, the Ngarrindjeri from the Coorong, the Naranga from the York Peninsula, and the Kaurna people from here in the Adelaide Plains. The language that I just spoke to you then was the language of the Kaurna people. And I acknowledge that the land that we meet on today is their traditional land. I ask that we all respect the Kaurna people and their land, and also thank my elders and ancestors for respecting and preserving this country before us. Let us remember our journey. Let us remember the tears. Let us remember our dreaming. But most of all, let us remember the Aboriginal people. My dear brothers, my dear sisters, I thank you all, and on behalf of my Ghana elders and ancestors, I say Mani na budni, which means welcome. So when I ask you, when I say na mani, that means are you good, okay? And if you're good, you say mani I, I'm good, all right? Na mani. Very good. So that's just an easy piece. I'm going to try to cram about 40,000 years worth of history into about 5 minutes for you. So I hope you've got your thinking caps on, all right? Before I go any further, I'd like to introduce this instrument here, pay my respects to this instrument here, the humble didgeridoo. This instrument doesn't come from down in that part of our country. It comes from the top of Australia, in the Northern Territory, in a place called Arnhem Land. And its traditional owners are the Yolngu people. So it's very fair now that I pay my respects to the Yolngu by saying Mang Mak Yolngu. We're just saying thank you in their language. So they share this instrument with us, so we could be here sharing the humble sounds with you. Of course, the didgeridoo is spread all throughout the country as a bit of a voice for all Aboriginal people throughout our country. And it's great for the youth to pick up, the young men to pick up, because it is a man's only instrument. Because as we know, men can't have babies, can they? No. It is only 2013 though, lads, so be careful. We don't know what the future holds for us. But men can't have babies, and our ceremonies will go for a long time. When we play this instrument, we play it from down low in our stomach. So it's said to make women sick with the reproductive system and so forth. So it's culturally appropriate that men only play this instrument. Now before I go any further, I'm just going to start off with some traditional sounds. At the back here we have the River Torrens, Garawirapari, the Red Gum River. We go back about 200 years, we can picture a big red kangaroo hopping along. We call him Taranda. Can you say Taranda? And that big red kangaroo, there's quite often a little baby joey kangaroo in there. And when you hear that and you're watching them bouncing along, it might sound something like this. Unfortunately, I don't think the weather's the best for all of us, is it today? My throat's a bit croaky there. Another animal that we have that's an icon is the emu. We call that one curry. Can you say curry? Not curry. Who said curry? Curry, the emu. On a night like tonight, though, some curried curry would be very, very good, wouldn't it? Now, the curry, the emu, it makes a bit of a grunting sound. Something like this. And at that point, you better hope you can run 60 k's an hour, because they run at about 50. Another animal, of course, that's a predator to these two creatures is the wild dog, the dingo. We call him Gudley. Can you say Gudley? Gudley. Now that dingo, he doesn't bark like other dogs. He howls, similar to a wolf. Of course, that's when all the kangaroos will take off running away. Who goes camping much? I go camping quite a bit up on the river. And during the summer, every morning, about 5:30 in the morning, there's this little tiny bird that wakes me up. He thinks he's cheeky too, the kookaburra. And he's laughing at the dingoes chasing around all the emus and kangaroos. And he knows he's going to wake me up out of my tent, because I've got this bright blue tent, and he knows my tent. So he sits above the tree, right above mine. We call the kookaburra Nungana. Can you say that one, Nungana? Nungana. So this is what I get woken up to. I think I've got a fish on my line, but then I realise he's just playing games with me. Now, of course, during the duration of our lives, I'm sure many of you have heard that Australia is they reckon that Australia is behind in the rat race to the rest of the world with technology and iPads and iPhones and applications and all this sort of stuff. But you think about it, while the rest of the world were busy inventing the wheel, Aboriginal people were down here working with aerodynamics, yeah? Talk about aerodynamics, we talk about the boomerang. We call that boomerang wadna. Can you say wadna? All right. So after I do the sound of the wadna, I'm going to play a smooth rhythm for you, so I hope you enjoy. But next time I go camping, and that little kookaburra wakes me up early in the morning, I'm going to sneak out the tent with my wadna and I'm going to chuck it at him. Reckon I got him? So once again, ladies and gentlemen, it's been a pleasure to come out and welcome you to the country on behalf of my people. I believe in what you're fighting for up here. I believe that one of the most important ways to access and to get a better understanding for Aboriginal health is to understand Aboriginal culture. So to get out there and talk with Aboriginal people and understand Aboriginal culture, how they grieve, how they deal with their losing their elders, and how they deal with different depressions and emotions and stuff like that. It's very important to understand culturally. And I always tell young Aboriginal people, if you want somebody to respect you as a young Aboriginal man, you need to respect whoever that person is, no matter where they come from in the world, because we are on our way and we are a reconciled country, and it's very important that we all come together and together as one, to walk together as one in harmony. Once again, my name's Robert Taylor from Kumakara Dance Group. Also work with a youth group in Port Adelaide, and I think that's my biggest achievement, is out there teaching the youth, passing the culture on, so that they could be up here one day and I could be sitting back having a break in the Bahamas. So thank you very much. And in my language, we don't have a word for goodbye because it's so final. So we're going to say see you later. And the way we say see you later is nakora. Can you say that one? Nakora, nachalia. Thank you.
Okay, thanks, Rob. Appropriate, we should have a welcome to country for one of the few Indigenous forums that we've been having this year. So thanks so much, Rob. Rob comes from a big family in Adelaide here too, so enough family members. Okay, so what this evening's going to be, what we'll do is we've got 3 speakers. Each speaker will have 10 minutes. If you can hold your questions until after the 3 speakers have spoken, done their presentations, we'll then have questions from the floor. So we've got 2 roving mics who will run around and try and get you before you say something so that everybody can hear you. But the whole idea is we let the speakers have their say, raise some issues that hopefully that you want to engage with, and then we'll have a bit of a talk about some of those points. So the three speakers in order of will be Carla first, then Lisa, and then Janet. Or is it the other way around? That's right. Okay, so I've got the full line notes. Okay, so the seminar series that we're about to start tonight, it's been designed to showcase the latest work of some of the university's thought leaders. And I suppose, when we're talking about Indigenous leaders, we're looking at good research evidence that comes out of the community. There's been a lot of work done in Aboriginal communities, but very, very little is good, solid, rigorous evidence that we can actually use to make a difference to the community. So when we're talking about research leaders, it's not just Aboriginal people that we're actually talking about. We're talking about people who want to work with Aboriginal communities, who want to be able to engage and collaborate with communities. Aboriginal communities tend to say, well, we're over-researched, but when you actually look at what's been happening on the ground, a lot of the research that's been done in the past has been around social science, and it is of very little use to Aboriginal health services. So, to hear researchers who are engaging and helping Aboriginal communities to try and get that research evidence to make a difference in their community, it's always a pleasure. Yeah, so these seminars, they are powerful forums to be able to provide, and I suppose the most important part about it is that while the researchers are actually talking about their work, that they engage with the audience, that you get a chance to engage with them about some of their models, some of their methodology, some of the interesting things that they've done. So tonight is about an interactive model. So once the presenters have actually done their talk, we're hoping that there'll be a lot of questions from the floor. And just remind us that there's a roving mic that's going around, so wait until the mic gets to you before you actually ask the question to any of the presenters. Okay, so what we'll do is we'll kick off tonight, and we'll ask Dr. Carla Canuta to come up to the stand. Carla is a Torres Strait Islander who has lived and worked in remote Aboriginal communities throughout Far North Queensland. Her formal qualifications includes a degree in sports science, graduate diploma in Indigenous health promotion, and awarded her PhD in 2013. So Carla is one of those growing numbers of Aboriginal and Torres Strait Islander young people who is gradually getting their PhD. And you have a fan club up the back. Her presentation will briefly describe a research trial conducted in Adelaide that formed the basis of her PhD and a new collaborative research centre excellence between the University of Adelaide, Wardley Pringringa, and the National Aboriginal Community Control Health Organisations called NACCHO, that will focus on knowledge translation to improve the prevention and management of chronic disease for Aboriginal and Torres Strait Islander people. So without any further ado, Dr. Carla Canuta.
Okay, am I on? Yep. Thank you, Elwyn, and thanks to the University of Adelaide for inviting me to come and talk today at the Research Tuesdays. You've said half of what I wanted to say, Elwyn. But thanks. I'm currently employed at Wardley Pringringa, as Elwyn said, and we're the Aboriginal Health Research Theme down at SAMRI, the South Australian Health and Medical Research Institute. So today I just wanted to talk briefly about some of the health disparities. I wanted to show you some of the Wardley Pringringa's research, talk a little bit about the Aboriginal and Torres Strait Islander Women's Fitness Program, which was my PhD, and then lastly about the CRE in Aboriginal chronic disease knowledge translation and exchange, which of course is that program of work between the University of Adelaide, NACCHO and Wardley Pringringa. So you've probably seen this slide before. The difference in life expectancy between Aboriginal and Torres Strait Islanders and non-Indigenous Australians is quite well acknowledged, and most people have heard of the government's Closing the Gap program. So in 2008, COAG agreed to 6 ambitious targets to address the disadvantage faced by Indigenous Australians in life expectancy, child mortality, education and employment. The first of which was to close the gap in life expectancy within a generation, which was 2031. So this data is from the Northern Territory, and the bottom lines, this is males on the left and females on the right, the bottom line is life expectancy trends for Indigenous people, for men and women, and the top line is for non-Indigenous. And what this slide also shows is this green space here is the gap that's attributable to non-communicable diseases. And most of that is made up from cardiovascular disease, type 2 diabetes and other avoidable chronic conditions. What this graph doesn't show though is the underlying picture of ill health and reduced quality of life fuelled by the determinants of health, which I won't go into today. On the positive though, there's quite a number of quality research projects happening across the country. Research has a very important role to play in ensuring that the resources that we have, the very limited resources that we have, are going towards initiatives that will have positive outcomes for Aboriginal and Torres Strait Islander people if we are ever going to truly close the gap. So this slide is from SAMRI, the Aboriginal Health Research Unit, which of course is led by Professor Alex Brown. Walli-Paringa has a broad range of research with 3 main programs across chronic disease, psychosocial determinants and disparities and inequalities. And you can see from the slide that they all sit on 4 key pillars of clinical research, health services research, knowledge translation and capacity building. Walli-Paringa's goal is to generate positive long-term change for Aboriginal families and communities in South Australia. Walli-Paringa, to do this, has developed some really strong relationships with key partners in South Australia, with the Aboriginal Health Council of SA, with the Council of Aboriginal Elders of SA, with the Adelaide's 3 universities, so Uni Adelaide, Uni SA and Flinders, with Nunkanmore and Yunti, the Aboriginal Medical Service in Adelaide, and NACCHO. And we collaborate with other Indigenous researchers on national and international research projects. So here are some of Walli-Paringa's current projects. You can see really diverse topics: chronic disease, wellbeing models, cancer research, diabetes, cardiovascular omega-3 trial. And we've also got some other projects there, unfunded stuff around next steps, the Accord and landscape. And as Elwyn was saying, when asked, a lot of people seem to think that Aboriginal health is over-researched, but from some of our work that we've done through Next Steps, what Walli-Paringa's done, we've found that there's still a lot of questions we want answered, and we've had enough of describing the problem, and now we need to know what to do about it, and that's where research should be concentrated. So I wanted to share a little bit about my journey, about how I ended up in Indigenous health research. Before I came to Walli-Paringa, before CREATE, before my research career, I'd studied sports science and Indigenous health promotion and spent several years working in remote Aboriginal and Torres Strait Islander communities. I was frustrated by the lack of evidence that I could draw on to inform my work, and there was almost nothing to advocate for where I wanted to put my resources and what I wanted money to do. So my PhD project was the Aboriginal and Torres Strait Islander Women's Fitness Program. It was a group-based program aimed at reducing metabolic risk factors, improving the management of chronic diseases such as type 2 diabetes, whilst enhancing social and emotional wellbeing and connectiveness for a high-risk subpopulation, which was overweight Aboriginal and Torres Strait Islander women. So I developed and implemented and evaluated the program for my PhD and the trial, but the design of the program drew on many, many years of work experience and from the limited international data that I could find, literature I could find. And I worked very closely with women in the Torres Strait to develop the pilot study for this, which was the Thursday Island Women's Fitness Challenge. So the program ran in Adelaide from 2010 to 2012 and recruited over 100 Aboriginal and Torres Strait Islander women. Pivotal to its success was a local advisory committee of committed Aboriginal and Torres Strait Islander women who believed in the project and were helpful in every aspect. The program had modest yet important metabolic health outcomes. including some weight loss and improved HbA1cs, which are a measurement of blood glucose control. Importantly, the project was able to produce publications, not just peer review, but other publications which will hopefully inform and advocate for future programs. The 12-week program now, plus the resources that go with it, have been produced as a facilitator's manual and are available for not-for-profit organisations to run. So that was one small project that came from quite a small bucket of NHMRC money that actually has got an outcome that there are different organisations around Australia now that are starting to run the Aboriginal and Torres Strait Islander Women's Fitness Program. So CREATE is the new CRE in Aboriginal Chronic Disease Knowledge Translation and Exchange. And it's the collaboration again of the University of Adelaide, so both the School of Translation Health Science and the School of Population Health, NACCHO, the National Aboriginal Community Controlled Health Organisation, Wadley Paringa, the Aboriginal Research Unit down at SAMRI, and the Joanna Briggs Institute. So CREATE acknowledges that the bulk of life expectancy gap is due to chronic conditions. So the idea is if we focus on the prevention, treatment and management of chronic diseases for Aboriginal and Torres Strait Islander people, that we'll have the most potential to close this gap. The CREATE partnership has been established to support Aboriginal health sector to better use existing knowledge and develop guidance on best practice for chronic disease prevention and management. We have two main objectives. The first is to collate and synthesise existing evidence and, where necessary, develop and collate new evidence to inform guidelines, policies and or other tools focused on improving care and outcomes for Aboriginal and Torres Strait Islander people with or at risk of developing chronic diseases. The second objective is to enhance the capacity of Aboriginal and Torres Strait Islander health service providers and researchers to conduct translation health science. It's a 5-year NHMRC funded program of work. We only just got the money in October last year. It's a national program, so it will be spanning across every state and territory. And we're currently now going and visiting all the NACCHO affiliates in the states and territory to collaborate with them on this program. And importantly, this program of work is led by a leadership group. And that leadership group doesn't just include the chief investigators, it also includes representatives from the Aboriginal health sector. So we have CEOs from affiliates and from Aboriginal health services across the country informing the priorities of the program and keeping us on track for what our research should be about. So CREATE will be formally launched at the NACCHO Summit this month. Alex will be giving a keynote presentation and we'll be holding a lunch session. So it's a real opportunity for all of the health organisations to get involved in the program of work. And the diagram on this is our logo that we came up with our leadership group. And in the centre you can see our core values, our leadership, culture, values and ethics. And then these are the 7 pillars of Aboriginal health that they saw of Aboriginal health. So we've got best practice care, sustainable funding models, workforce, defining our outcomes or our key performance indicators, quality improvement, accreditation and governance. And I might leave it at that. Thank you.
Okay, thanks, Carla. I suppose the CREATE project hasn't got fully underway yet, but I think the other interesting part about Carla's presentation is her PhD. Aboriginal women tend to be the principal carer in the community. So, you know, them looking after themselves and them understanding about the whole range of exercise and nutrition actually has a flow-on effect to the rest of the community, the rest of the family and then the community. So, you know, like even though it was just a small project for her PhD, it does have a significant impact that if it was done within the whole communities, it would, you know, make a big difference around nutrition, diet, a whole range of stuff. So if women are doing something, the rest of the community tends to follow. So getting women to participate is probably the challenge. So it's just something, a bit of food for thought for later on. Okay, so just moving on, we have Associate Professor Lisa Jamieson, who's the next speaker. Lisa is a public health dentist with a keen interest in oral health research of Indigenous populations, both in Australia and internationally. She is the Director of the University of Adelaide Indigenous Oral Health Unit, embedded within the Australian Research Centre for Population and Oral Health, and is currently leading 3 randomised controlled trials involving Indigenous oral health. Lisa is the recipient of the NHMRC Career Development Award and a member of the International Association for Dental Research. Lisa spent considerable time working as a dental volunteer in developing countries before completing her PhD and joining the Australian Research Centre for Population Oral Health in 2004. So over to Associate Professor Lisa Jamieson.
Thank you very much. I too would like to thank and acknowledge the University of Adelaide. It's an honour to be speaking here tonight. And I'd also like to thank and acknowledge Rob Taylor for a wonderful welcome to country and the didgeridoo playing. It's really important to have that sort of component to these talks. I would like to acknowledge and pay respect to the traditional custodians whose ancestral lands we're meeting upon here today, and I acknowledge the deep feelings of attachment and relationship of Indigenous people to country. Just a wee bit of background regarding oral health. So, in the scheme of general health, oral health is the poor cousin. It often gets neglected, but it's a basic human right. As anyone who has had a toothache can attest, poor oral health can lead to pain, loss of sleep, poor work performance, inadequate diet, and economic stress. Importantly, what we've found in the last decade really is that oral health is linked with general health, with links between oral health and diabetes, stroke, cardiovascular events, and preterm birth. That's just a few. Oral health historically has been a good litmus test of general health. In the First World War, it was used as an indicator of a soldier's fitness to fight, with the general assumption being that if a soldier's oral health was not so flash, then the general health was likely not to be so good as well. And you certainly don't want to have a soldier to have raging toothache out in the field. So that was considered way back, sort of, you know, nearly a century ago, as being important. When we consider Indigenous oral health, regrettably, Indigenous Australians score worse on every oral health indicator. So when I say oral health indicator, I'm talking about dental caries or dental decay and periodontal disease, which is the disease of the gums, relative to their non-Indigenous counterparts. The evidence suggests that they have a greater reported frequency of dental pain, they have more missing teeth due to dental disease, and poorer oral health-related quality of life. It's quite devastating that the dental disease inequalities are most profound among young Indigenous children, with Indigenous children receiving dental care under a general anaesthetic, which is not itself without risk, at 12 times the rate of non-Indigenous children. So you might appreciate Aboriginal children who are out in remote communities present to a dentist with you know, up to sort of 8 or 10 decayed teeth. These teeth need to be pulled out. It's very difficult to pull out a tooth in a young child without the child either being sedated or under complete GA. That child then needs to be moved to, in South Australia's case, to Adelaide. They have treatment at the Women's and Children's. But the requirements for having a GA is to be fasting. A child can't have treatment without, if they've had food. For some reason, often this information doesn't get passed on adequately, so the child eats breakfast, we can't see the child gets sent back to the community with the tooth problems still present. Enormous costs on no matter what scale you look at. What we have been finding over the last 10 years of our unit's research is that Aboriginal communities are becoming increasingly concerned with the oral health status of community members, with many elders reflecting on a time less than 30 years ago when Aboriginal Australians had better oral health than their non-Aboriginal counterparts. We know this knowledge, but it's largely anecdotal. There's been little work done in the field of Indigenous oral health in Australia. So at our unit, the Indigenous Oral Health Unit from the university, we are committed to undertaking research that has directly translatable outcomes. I think as Alwyn alluded to, we've done enough description. We need to actually move now to sort of interventions. So to this end, most of our projects are randomised control trials. This seems to be the area that the NHMRC are heading towards in terms of funding. And there's some acknowledgement that this is the most scientifically rigorous study design. So in the last 5 years, we've generated over $10 million in competitive grant funding. And of course, we are deeply invested in capacity building, and half our staff are Aboriginal. Just examples of 3 of our recent projects. We have just completed a periodontal disease intervention among Indigenous adults in the Northern Territory in a bid to reduce risk markers for cardiovascular disease. So we recruited around 273, I think it was, Aboriginal adults in the NT who had some level of periodontal disease. We then provided comprehensive periodontal treatment to half the group. And we found that it actually did improve cardiovascular outcomes. So at the end of that study, we then provided the care to the non-intervention group. So that's a wonderful outcome for us because it enables Aboriginal dental services and Aboriginal community-controlled health services to actually provide some evidence of why dental services should be continued. We also conducted a randomised control trial around oral health literacy among Indigenous adults in Port Augusta. Oral health literacy is a bit of a broad description of the skills required for a person to navigate themselves through the oral health system. It's not always easy to do this. There's all sorts of different pathways that you can do. It's not always culturally appropriate, and it's certainly not always obvious what you can be doing. So oral health literacy intervention was really around providing education, but very tailored education and very context-specific oral health-related information for our group. And again, we found that those involved in the intervention, they got it. They knew how to then make a dental appointment. They felt much more empowered in terms of what their rights were. They felt much more secure in their knowledge of what the role of oral health was in general health. And again, that has slowly been starting to be listened to among the policymakers. And the one that we've still got out in the field is one around early childhood caries, so dental disease among young children. This is a tri-collaborative partnership, so we have partners in New Zealand and Canada. There are 4 components to the intervention arm, so a wee bit complicated. We have dental care to mothers provided through pregnancy to reduce that bacterial load during pregnancy. There's some evidence to show that the bacteria in mothers' mouths can be what we call vertically transmitted to the children who are born. So the babies don't have bacteria in their mouth per se. It's they often obtain this bacteria through the mums, through kissing, through being very close to their babies. So we're certainly not saying you can't kiss your baby, but if we can reduce that bacterial load of the mum, it's going to reduce the bacterial load in the baby, which then makes early childhood caries much less of a risk. We also slap on fluoride varnish to the teeth of the children at 6, 12, 18 months. We've got motivational interviewing, which is a brief form of psychotherapy, and anticipatory guidance, which is a fancy word for dental education, which is tailored to specific age groups. Just a wee bit more information about the Early Childhood Caries project. So in Australia, we recruited from February 2011 to May 2012, recruited through a number of different stakeholder groups. And we were very proud to recruit 464 mums who were eligible. The total number who were eligible was around 650. So we managed to recruit around 2/3 of those, which is quite good, just to blow my own trumpet there. In New Zealand, they worked primarily through a Maori healthcare provider in the Waikato, Auckland catchment. They commenced October 2011 through to December the following year and managed to get 250. And in Canada, they worked in 5 different reservations, primarily through health organisations again, and they got around 546. So collectively, we've got over 1,000 mums through those countries. Just to let you know how we're going, just in Australia, So it's a randomised control trial, so we have our baseline group, and then we have our what we call the intervention group and the delayed intervention group. And the children are assessed at the age, 2 years of age, so we're currently in that phase at the moment. Oh golly, okay, move it on. Just to say that we have managed to retain about 90% of the children. So that's due to our 4 Aboriginal staff who have done a great job retaining. Okay, just a little bit of evidence around some of the findings we found at baseline. So we had quite a comprehensive questionnaire, and one of the sort of domains we were interested in was experience of racism. So this is outcomes from a Maya instrument, which is developed by a collaborator in Melbourne. And I'm just going to highlight to you some of the areas in which racism was experienced by the Aboriginal mums in Australia compared to their counterparts in New Zealand and Canada. So there was a lot more racism in Australia experienced at home or by neighbours. Around just under a quarter of our mums experienced racism by police, security people, lawyers or the court of law. And this is outstanding. Nearly a third of our participants had experienced racism by members of the general public. Almost half of the participants had experienced racism in at least one of those settings, with around 1 in 5 experiencing it in between 4 and 9 settings. Just quickly around the discussion, so the literature does suggest that with respect to their Indigenous counterparts in other colonised countries, Aboriginal Australians experience greater social inequalities. Michael Marmot is quite a famous epidemiologist. He suggests that improving lots of social determinants, education, employment and income is the only way forward, really. Gracie and colleagues, Michael Gracie is an Australian academic. He adds that the health of Indigenous populations can only improve when there's acknowledgement of cultural security, connection to lands, language and culturally defined notions of health and wellbeing, which is what Rob mentioned before. Nearly there. We need to ensure that those involved in Aboriginal health research acknowledge that history matters. Of course, there's been government-mandated reparations since the 1970s, but there's still long-standing inequalities which have an impact. Okay, I'll just let you read that last little dot point. Because many Aboriginal communities are wary of research, and researchers in particular, particularly randomised control trials, in our unit we place a lot of importance in establishing and maintaining relationships and trust with key community members. This is time consuming and it can take many years to establish, but it cannot be rushed and it cannot be faked. Closing the gap between Indigenous and non-Indigenous health outcomes in Australia is best informed by culturally sensitive, rigorous health research. I'd like to acknowledge my fellow CIs and funding. And just a bit of a plug, we are hosting an International Indigenous Oral Health Conference at the end of August. We'd love to see you there. Thank you.
Okay, thanks, Lisa. As you can see, women feature quite heavily again, in particular pregnant women. So, you know, if we can actually keep mum and bub safe, if we can get mum to have a healthy birth and look after baby's teeth, health, the downstream effects, we can actually reduce the downstream effects quite significantly. So the work that Lisa and ARCPO are doing around trying to find that research evidence, trying to convert what we already know into some kind of evidence so that we can actually use and go to the government and say, well, you can actually save a lot of money in a 20-year period if you start doing this here, rather than just trying to ad hoc Aboriginal health. I suppose the other important thing is that a lot of Aboriginal communities don't have access to dentists anyway. So when they actually do get to have a chance, the line trying to get into the dentist is quite long. So not every Aboriginal community has a dentist or has access to a dentist. So when it gets to a critical point, then they're brought into town or got taken to a hospital to get those services. And we just found out that one of the health services actually has lost a seat just recently. So there's less opportunities than there has been before. So dental part is really important. And as Lisa made a point about the gum, the relationship between gum and cardiac. Yeah, so when we get to an older point, bad gums just add to the chronic problems that we've been having. Okay, so the third speaker is going to be talking about patient pathways. And so Dr. Janet Kelly is an experienced researcher and community health nurse. She has worked and researched in Aboriginal and mainstream primary and tertiary health care settings in urban, rural and remote areas. Dr Kelly coordinates stage 1 and 2 of the Managing Two Worlds Together, City Hospital Care for Country Aboriginal Patients, project focusing on improving metropolitan health care for Aboriginal people, particularly as those from rural and remote areas. She is currently leading stage 3, improving Aboriginal patient pathways or patient journeys, a knowledge translation project adapting the patient journey mapping tools developed in stage 2 for use in quality improvement education. So over to Janet.
Thank you. Is this on? Thank you. I too would like to pay my respects to the Kaurna people and the elders past and present. I'd also like to acknowledge that the work that I'll be talking about has actually involved some quite wide collaborations between Aboriginal people firstly and their families and communities, the Flinders University, Adelaide University, Baker IDI, the Heart Foundation, the Aboriginal Health Council of South Australia, SA Health, NT Health and the Loitche Institute. So different parts of this, the different projects have been funded through SA Health and through Loitche Institute, and now there's some continuing work with the Heart Foundation. So the situation, as has been discussed by Lisa, and I'm having a mental blank, sorry Carla, I do this, mental blanks, is that often people, they start from home, excuse me, that plane, I forgot it does that. Anyway, the plane's moving, going in and out the clouds. So they start from home, they might go to the local health services, to the regional hospital, to the city hospital, and then have a journey home again. Home might be Murray Bridge, it might be Sojourner, it might be Oak Valley, it might be somewhere out from Alice Springs, it might be out somewhere from Darwin. So when we were looking at patient journeys, we started looking in South Australia, but of course we see people in the Adelaide City hospitals from Northern Territory and from parts from Western Australia and Northern Territory and New South Wales as well. So when we were looking at journeys, we were looking at the barriers, enablers, the gaps and strategies in care for people on these journeys, and we looked at planned, emergency and urgent journeys. We looked at people coming down for an outpatient's appointment, an inpatient's appointment and for investigations. We looked around cardiac, renal, maternity, eye surgery, accidents and a few other situations that people were in. So we spoke to staff in city and country health services, and we also spoke to Aboriginal people themselves in country areas and their carers about their journeys. What we've developed over the last 5 or 6 years is a way of mapping the journeys and a way for staff in both country and city to be able to work together and also to work with people and their families to have a better understanding of what's happening in that journey across all those different parts of the health service. So someone might go, if we go back here, they actually might start in an Aboriginal community controlled health service. The GP may or may not be anywhere near there. The regional hospital might be a small SA Health hospital. Then they'll come to a city hospital. They might actually need to stay in a hostel, and then it's all the process back again. The different electronic case notes and the different systems don't talk to each other, so it's really important that the staff do. Sorry, going there. So the way that we found it was useful was to do a visual map and start looking at, well, what are the distances? And what is it that people, what parts of the health system are people travelling through? Things like, is it the middle of summer and is it a 2-day trip? And does the family have a really good car, or is there actually real concerns about dehydration? Then the narrative, the person's story told in the context in which it happened. So as we spoke to a range of different Aboriginal people about their experiences, we could pull together the themes from different stories. But there was also something incredibly powerful about someone's whole story. Well, I started from home and then this happened, and then this happened, and then this happened, and then this happened. The person might have got flown in RFDS from a car accident, and the family travelled in for 2 days, and by the time they got to the hospital, they were really stressed and really worried. And then maybe staff didn't realise why they seemed so anxious when they got to the hospital. So we looked at, what was happening for the person, what was happening for family, in the context in which it happened. But it's really important to consider the whole person entering the journey. You know, what are people's personal, emotional, social, family, spiritual, cultural, physical things? You know, what is important for any of us when we enter into a health system? You know, which bits of ourselves do we want to bring in? Then looking at the underlying factors that impact on access and quality of care. So the location, you know, are you able to access a health service down the street? Or actually, do you need to move because you've just had a renal dialysis and there's nothing within 600 k's of home? So you actually need to leave your farm and your stock that you've spent generations getting to a certain level. What's the impact of the illness or injury? You know, so many times people said, I'm a really strong person, I've worked on the railways and, you know, I'm really strong, and then I got sick. You know, do people explain things in ways that people can understand? Is the language and communication really clear? Do people have the financial resources? And do the health services and support services have the financial resources to support people? And are there different concepts of health and healing? Then we brought together the multiple perspectives so we can consider what happened for the person, their family, and for staff. Because what we found with staff is staff are doing fantastic work in pockets, but often it's not connected across the system because our system is so disconnected, our health system. So this is a map of the mapping, a diagram of the mapping. So you get the person's story, you get the staff experiences. As they look at the case notes and they listen to what's happening, you get a bit of an idea about sort of the general gaps and strategies. You come up with a case study, not saying the person is a case. There's a term we used to say, this is a body of work, when I use it in this form. Then looking at, well, what are the questions and what gaps and strategies become really obvious from this person's story? And if we compare those to a standard or the kind of care that we'd like to provide, how does it measure up? So in this case, suppose these are 3 different people's stories about cardiac care. The first person who's up in the blue area of what we would hope would happen for someone with cardiac care might have had a heart attack in the city, at work, the ambulance was called, they had ambulance cover, they got to the hospital, they could understand what was happening, they had really timely care and they had a really good outcome. The second one down, and these are all based on stories that we heard. Someone's in a really remote area, they're actually really young, and surprisingly they had a bit of a cardiac event after playing sport. And then they're really remote, but they have really good care at the remote area health service. The nurse got onto it really quick, having been alerted by the health service, gave the medication so that the clot started to be broken down straight away. The doctor in Alice Springs or Darwin redirected the RFDS plane, recognising that this was really important. By the time this person got to Adelaide, the clot was actually already breaking down in a good way, and they had a really good outcome. They could have had the trajectory that would lead them down the black line, but actually it changed. The green arrows here indicate where are the points that the health system and the services can actually intervene for good outcomes. Everything went into place really well for the story, and so even though someone was in a really remote place, didn't mean that they needed to have a negative cardiac outcome. If things are in place, you can have really good outcomes. The third line, unfortunately, was heard too often. Maybe someone's in a regional town, maybe they don't have a phone, maybe they don't have ambulance cover, maybe by the time they get to the hospital they're actually quite agitated and so are their family, and they're actually viewed as a security risk, or maybe they might be drunk. And so sometimes people might make assumptions about what's happening for people, and so their service and their delivery could get a little delayed, and so they didn't get the ideal care. So sometimes that could happen as well. So we found these stories and this diagram that could be a cardiac story, similarly with midwifery stories, similar with renal stories. You could pick any of the different stories we were hearing, and depending on what was able to be put in place, and often the complexities are really predictable. And if you can have things in place and if different parts of the people in different parts of the health journey can talk with each other, and ensure that there is communication and there is coordination and there is collaboration, that when the kids come in to get their teeth done, that they know they have to fast. How simple is that? But it could be a 2 or a 4 day journey. that, you know, they either get saved or it gets wasted, according on whether that one piece of information was able to get through. And that can be tricky. But, you know, what are the things that make that work? So they're the things that we've been working on, and working with Aboriginal health workers and staff in city and staff in country and electronic records and paperwork, and going, how do we make this work? And so that people going through there feel like they've been acknowledged and they've been supported and they know what's going on and they get to be home and they get to be well. Thank you.
Okay, thanks so much for that, Janet. I nearly forgot your name.
Oh, that's good, not just me.
It's late in the afternoon, heat. I suppose the other thing about, I mean, like what Janet's talking is that it's not just, you know, people tend to blame because it's rural and remote, that, but it's also about a systematic approach to making sure that everybody's on the same page, you know, like, and that we're all practicing the right and the same way. So even if you do live out in remote areas or you live in a rural area, there's still a right way and a wrong way of doing something. And, you know, it's about us getting that right as well as the remoteness. So, you know, the infrastructure's out in the remote areas is maybe limited, but that does, you know, there's still a way we can train people to react in a particular way and not make perceptions about people or not make judgments about people. And so that's the other thing about this. But I think the other part of all this too is the discharge plan that we need to talk about too. So coming into the town, coming into the hospitals, if they come in through multiple places, getting them back home and getting the discharge letters to follow them as well is the other issue, so that they can get follow-up care back in the communities. Okay, so what we're going to do now, so hopefully everybody's got a lot of questions to ask the three presenters. So this is where we get into some nitty-gritty questions from the audience to the presenters. So if the presenters would like to come up and sit in the front here so they can be picked on. And so plenty of questions. Okay, so you've heard I suppose they're pretty diverse presentations. So questions, we have roving mics, so just put your hand up and wait for the mic to get there, and we'll take questions from the floor.
Thank you. Commendations to all the presenters as to what you're doing. I'm a polio survivor from the 1950s, and our counterpart in Western Australia has been trying to find information about how many Indigenous people had suffered from polio in Western Australia particularly, or in Australia, and we cannot find anything. So what you're doing is you are creating health records. Excellent.
Thank you.
Has there been any research on what helps those Indigenous who are flourishing be able to flourish, and is there a big enough sample to have that knowledge?
It's on? Okay. I don't really know how to answer that. I think there are other people in the room that are probably better able to answer that. Anyone at the back? It's something that we're interested in, though. Instead of just looking at the deficit model and looking at illness and ill health, we're definitely interested in wellness and what helps keep people well. And there is one project happening at Wadley-Paringa that I think is looking into that to some extent. But I'm not on that one. Sorry, I can't talk about it too much.
I can talk to that just in the oral health context. So the project that we had in Port Augusta, we were very interested in looking at what we call self-efficacy, so a person's confidence in their ability to do well in any given outcome. And our outcome was around looking after their teeth. And what we found was that those who were highly self-efficacious had enormous resilience. They were strong socially and emotionally, and they had a lot of network connections with community. And so what we were able to do was to do some network analysis and find that this one in this group of 400 we had 10 such people, and they were connected to all the other 400. And so that points to two questions. It points to the role of resilience and self-efficacy in health outcomes. But I think more critically, especially if we're moving into the realm of doing intervention sort of work, I don't like that word, but intervention work, is around looking for our strong, efficacious, resilient folk because they've got networks and community. And I think that that's probably generalisable to many Aboriginal sort of locations in Australia.
One of the things I got to see when I was visiting places was in Kubapedi. They have Umina Aged Care, which is this beautiful facility which provides really high quality aged care done in a cultural way. And so they'll have whole of aged care camps, and no one gets left behind, even the person who's bedridden and incontinent. And they've all got their own swags, and they all do the risk assessment, and everyone goes out to camp, and they all do really important connection to country, and it's really strong. And I remember one worker saying there's one chap who would barely get out his chair, but he got out there in the space where he needed to be, and he was up swinging the billy and doing things and doing, because it was tapping into the strengths and what people could do rather than, as you were saying, the deficit model.
Good question.
And I think the other thing is, I don't know about research, but the Males in Black up in Port Augusta, they're doing a lot of good work with young men around supporting them. So it's not a research project, but it's a project that actually is supporting men who are doing well and trying to make them better fathers, better men, help them with their social and emotional well-being. So they're probably like me. They probably run a mile if they see a researcher coming. But there's a project that's happening at the moment in Port Augusta around men and fatherhood.
Oh, good evening. Elwyn, right at the beginning you talked about the need for strong, rigorous evidence going forward, and the fact that there's a lot of, attempts at research along the way that possibly doesn't fit that criteria of strong, rigorous evidence. And given this is an Aboriginal agenda around evidence as well, just some comments about what the current overlay of the levels of evidence are and how that marries up with the way Aboriginal people regard the weighting of experience and meaning and obviously its application.
Nodding because I was agreeing with them. That's a great question, thank you. It's also quite a tricky question. I certainly acknowledge what you're saying with the role of experience and on-the-ground knowledge and that sort of thing. I guess what we have found in the past is that with the but the descriptive work that's been done in terms of research has been social sciences derived. And I'm not saying it's a bad thing, but unfortunately it doesn't inform policy because it's not quantitative. And so the rigorous way of moving forward with robust science is typically through what I was describing with randomised control trials. But randomised control trials, by definition, require a control group, and that is certainly not at all appreciated by Aboriginal community groups. And I guess when you have strong community links and you've done the correct and appropriate cultural consultation, there are ways to sort of mitigate that. You would always need to have a sort of a delayed intervention group so that everyone ultimately receives the intervention benefits. So I think that there needs to be an honest discussion around what is good science and what is good community practice.
I think, Michael, the family wellbeing program is probably one of those areas what you're talking about. There's a conflict between what Aboriginal communities think is a healing process as opposed to what researchers... Yep. Yeah.
Yeah. Yeah, yeah. Yeah.
With our health services research that we've been involved with, which is probably mixed method but probably more qualitative, it's been really important that we get a range of different key stakeholders to the table, and a large percentage of them are Aboriginal. So we'll have Aboriginal representation from community, but also from research from the Aboriginal Health Council, as well as having, you know, health economists, and bringing a whole bunch of different people together and having that open and transparent discussion about what is it that we need to do, where is it we need to go, and how do we need to do it in ways that will work for community, will work for health services and work for the funders. And you can nut it out and you can work it out as long as you all work together really respectfully, I think.
Question?
Janet, I wanted to ask you, I'm interested in chronic kidney disease. What sort of work is going on to raise awareness not only amongst Indigenous communities but also the health workers around them?
Okay, so I can answer your question in part, but there might be others who could answer it more. So there's a range of different work going on around chronic kidney disease. I was just actually reading up, a lot of work's been going on in Northern Territory. They've been doing lots of education and lots of work, and lots of different options of people around care and dialysis and prevention and education. And one of the things they were looking at is they've got the strong women's group, and the women actually being peer educators to each other. As Alan was saying, you know, the women is often the caregivers and the centre of families, you know, tapping into that skill and knowledge. And I know there's a lot of work that happens with Aboriginal health workers as well, and also people like, there was uncle who passed away who used to sing and do a lot of work in the top end around education around kidney disease. So there's so many things, and I'm probably forgetting many of them, but there's things that happen at community level, things that happen at worker level, service level. And I know with some of the CQI processes where health services get audited, and they look at, well, how many of the people in this community are you actually doing this and this test and health promotion on? So there's some quite structured ways that they're trying to capture and make sure those conversations get included in health visits as well. Does anyone else want to add anything?
This is a question to Janet specifically in regard to service delivery. I'm doing a research project in program evaluation for TB in migrant screening communities, and I'm aware that TB does affect Aboriginal communities. I just want to know whether there's been any focus on service delivery surrounding TB treatment for Aboriginal people, because it is the nature of the treatment itself is actually quite long and can be quite traumatic because it requires isolation of the particular individual. So can you give me any information about that?
Yeah, I don't know immediately numbers or any programs happening around TB, but I don't know if Alwyn saw someone who's up north. But the other thing I'm thinking of is, yes, there'll be programs that would be involved with that, and we can catch up later and see how we can work out who might know someone who might be able to help you. But also, I think it's really important to remember the history and the colonisation aspects, because the isolation and people being put off on islands sometimes never to return. There's another whole story behind any of those sorts of things as well that's really important. So I don't have a direct answer, but happy to catch up after. Does anyone else know? No?
My name is May-Britt Boren. I'm from Sweden. I can't speak Swedish very well, but I'm very I can't see any Aboriginal people here, and maybe it could be a language problem. That's all. Thank you.
I'll just answer a little bit because I've got the microphone, but I'll pass on. There's actually probably more Aboriginal people in the room than you might recognise.
I would just ditto that.
Yeah, there are quite a few of us here.
Are there differences between Aboriginal people and non-Aboriginal people with regard to genetic differences in their health? And if so, are we looking at those specific tendencies and trying to work out ways to cope with them?
That's a big question. But just so happens that we currently have an application in to do some research on some of that work, but it's not in yet.
Yeah. But it's also a bit touchy too.
It's a sensitive topic.
Area.
Yeah, but
it's a very touchy area for Aboriginal communities.
I can understand that, but it happens to the whites. My father lost all his teeth when he was about 22, and then all my teeth started to go when I was 22. Now, if I had been an Aboriginal person, I would not have a tooth left because of the way I was being treated. And I'm just wondering whether that could be one of the things. Have you had similar things like that?
yeah, yes, all the time. And I would like to throw a question back to the audience. We've had a comment around many of the audience being sort of white Australian of the dominant culture. So my question to the audience is from an experience that we've had recently. So one of our projects was that we provided free dental care to all of the pregnant mums involved in one of our studies. So we contacted 18 private dentists from throughout South Australia. 6 private dentists, so 1/3 of our target population, declined because they said as a policy they didn't treat Aboriginal people. And I think that as a dominant culture, we can't always be expecting Aboriginal people to fight their battle. As a dominant culture, that is not acceptable.
But yeah, I think the genetic one is coming up. I mean, the ethics committee has been looking at that for the last 2 or 3 years now about how, I mean, stem cell research was probably the big one, and now genetic research is probably the other big one that's coming up.
Hello, yeah. I'm currently doing my honours project around the COAG and closing the gap and looking at life expectancy, but I'm particularly looking at governance and leadership. And one of the problems that I've come across, because I'm also comparing it with Canada and New Zealand's Indigenous population. So the Maori people started recording their life expectancy in 1945, and we didn't start until 1992 in this country. And then a recent conversation with the Australian Bureau of Statistics told me, do not use that data. That data is not correct. And even the recent life expectancy data is not supposed to be used, per se. So my question to you guys, how much does that hinder our future development in these areas if we can't even get the basics right? And should we be looking more to the international realm, particularly in policy making, towards trying to close the gap in our Indigenous population? Look what Canada and New Zealand have done for theirs.
Well, that's an easy one, isn't it? Good question. And I think the point is, how can we close the gap if we haven't measured the gap? And of course you need good quality evidence to be able to measure that gap. I wasn't aware that the government is sort of saying that we can't use that 92 data because that's what everyone has been using. Your point about can we compare with other Indigenous groups in other countries, my answer would be I don't think so, because the histories are very different. They've got similarities, but Aboriginal Australians are not New Zealand Maori, they're not First Nation Inuit in Canada. It's an insult to think that it's sort of cross-country that we can make these sort of assumptions. But as to a solution for your honours question, I can't help you. Sorry, Carla might be able to.
I'm not particularly interested in measuring the gap. I think regardless of whether it's 17 years, 19 years, 23, it doesn't really matter. There's a massive gap in not just life expectancy, but access to services, in rates of chronic disease. You can measure it a million ways. And we know that there's a gap, and I think we just concentrate on what we can do and trying to close that gap and not worrying so much about the figures. There's quite a lot of data out there, different figures, and all the different communities are different as well. Aboriginal people and Torres Strait Islanders were heterogeneous in in composition, and we don't all have the same rates of disease, so we definitely don't all have the same life expectancy rates either.
And you also got the data linkages now that you can actually collect a lot of. So like you can actually use the data linkaging that's going on at the moment. So that's actually giving you a lot more specific information.
I'm just going to come over.
Oh, okay.
I'm just going to do a slight step to the left. But in thinking about how do we improve health outcomes, when we were talking to a group of really senior elder women in one of the remote areas, we said to them, what message would you like us to bring back to Adelaide? So that when we're talking to people in Adelaide, to staff and students and other interested people about how can we care for you better as senior elder people? And they all looked round the table and they were interpreting for each other. And in one voice they said, tell them to say hello. They said, when people don't say hello to us, we feel like a non-person. And then the nurse person in me goes, well, how do you actually provide good care if you're not even having a conversation with someone? So there's also that thing about basic human connection. So, the first step is let's connect and respect each other as people, and then let's work on there from there.
So hopefully that's a bit of food for thought. Okay, right up the end up there. Yep, you.
Hello, I work in the media, and specifically I manage the university's radio station, and I'm getting a massive echo here, so I'll see if I can keep talking. I'm interested to know from all of you which parts of your research or work you'd most like to have available to the broader public through the media. We've got a big commitment to covering health issues and Indigenous issues in their complexity, not in the simplistic way that we often find occurring in mainstream media. And I'm really keen to know which sorts of things you'd like a wider audience to know about.
I think for me with the health services research, it's that yes, things are falling down a bit at the moment in communication. But if we work together, if we find ways of communicating and collaborating and coordinating together, there's actually really tangible ways forward that don't necessarily cost a lot of money. So there's actually some things that we can do right here, right now, tomorrow, to make a really big difference. And sometimes it's just about different ways of working. And maybe some of it is about giving people more time, and maybe it is about funding coordinator positions because they are so important. But there's also a lot of things that we can be doing.
I guess mine would reflect Janet's, just really the role of the dominant culture to sort of not accept unacceptable practices. The example I gave with the dental service providers having a policy of not treating Aboriginal people, exposing that, making it sort of out there because it's certainly happening, and just at a population level, just having zero tolerance around that.
I don't know. Wadley Paringa's involved in so many different things in research. But advertised through researchers, at least, I would say that we need to talk to researchers about doing research the right way.
Just over here first.
Hi, thank you for your talks, it was great. A lot of what I hear about is taking white man's medicine or white man's approach to disease and putting that into an Aboriginal community or setting. I'm just curious, is there an Aboriginal way of dealing with disease and healthcare that's been lost that we can get back? Is there research being done into how Indigenous people, look after themselves, or at least used to look after themselves, and kind of reinstating some of those practices? It was mentioned that Aboriginal kids used to have better teeth hygiene than white kids. So is that just due to changes in diet or decreased general health, or have there actually been practices that have been lost?
Absolutely right. So 20 years ago, when the Aboriginal population had better oral health outcomes than the non-Aboriginal population, it was because largely there wasn't so much soft drink available and that sort of thing. But there were a lot of very strong cultural practices that were being done. So, for example, the use of ash, of charcoal, and rubbing it with the gums, the use of sticks, stripping off the little bark and using them as cleaning sticks. So certainly, traditionally, historically, there has been, and just with respect to oral health, there's been wonderful examples of maintaining oral health. And I think you're right. I think that if we can have some sort of work promoting what used to always be done, the big battle for us with oral health and with obesity and lots of other things, diabetes, is diet. It's the availability of soft drinks. It's, you know, if we could get rid of Coca-Cola, half of our battle would be done. Diet is a huge issue. Access, availability, appropriateness, that sort of thing.
Just to add to that, if you start looking at what things cost in the stores in remote areas, you'll find that it's a heck of a lot cheaper to buy Coke than it is to buy something like milk or fresh fruit or water. And I know the Heart Foundation's just been working on getting a water fountain in one of the communities, because there was, in one community, there wasn't a spot where you could readily access water when you were thirsty. So, you know, some of it's a real access issue.
Just got to be careful with the water one, because up in the lands the quality of water isn't that very good either. So, I mean, generally water would be the...
Yes. My question is both to you, the panel, and also perhaps for the lady at the back from the radio station. When we came into the beginning of this talk, we had a wonderful welcome from your Aboriginal person with a didgeridoo, and my daughter actually did a thesis for her nursing degree on developing guidelines for Aboriginal children going into the Women's and Children's Hospital. And she found that one of the problems was that the nursing staff there were actually almost frightened. They didn't know how to deal with these different people. And so the wall went up. So it occurs to me that what Janet said about saying hello is one of the really important things in hospital when children are received or along the way. But the other side of this is for the radio station to help educate people as to how you do welcome Aboriginal people, how you do feel comfortable talking to them, and start to break down the barriers, because unless someone out there in the media is talking about these things and how you make relationships and what the right things to say are, and so that people understand the cultural differences and niceties, it's never going to happen.
Thank you. That's a great comment. I think that just from my personal experience, so I'm from New Zealand, you can probably work that out from my accent. Been here for 10 years now. And in New Zealand, we grow up inculcated with Maori knowledge, with Maori history, with Maori culture. We learn the language when we were at kindergarten. Maori are dominant in sport and politics and medicine and law, policing. The 15% of the population. It would be unheard of for us to have no understanding of their culture, and we're proud of it. The non-Maori people are just as proud of it as the Maori people. And so when we moved to Australia, I was gobsmacked. I couldn't believe the sort of not the sort of the overt racism that's certainly present, but just the general lack of knowledge about how to greet, how to say hello. I mean, it's not very hard to do, but to me it seemed that it wasn't part of a person's growing up. It was this sort of foreign thing that happened, you know, in remote communities. And yeah, it would seem to me that there would be a lot of sense in just making it just part of mainstream, just part of your school education. Yeah.
And yes, in talking to a lot of staff and students, people are often quite paralysed because they're worried about doing and saying the wrong thing, and so they do get paralysed by it. But then I also tell another story that was shared to me by a colleague who said she went to see a woman in one of the hospitals, and she went and said hello. She'd heard on the grapevine this woman was there. And she said, "Hello, Auntie, how are you?" And she introduced herself. And the woman burst into tears and she said, "Auntie, what's wrong?" She said, "No one's spoken to me in 3 days and I'm just so lonely." And so I kind of share that story and I say, well, yes, we might do the hello maybe not 100% right, but maybe not doing it at all is 100% wrong. So we just got to connect as people. Yeah.
Okay, then we've come up to 7 o'clock, so we've gone right to our time. So just like to thank the panel, Carla, Lisa and Janet, for giving up their time and I suppose interesting topics. So, and also thanks to you for coming and bringing some questions that we can actually start opening up. I mean, it is important that we start, like as Michael raised the question, you know, where is the pressure points between Aboriginal wanting something and Aboriginal having to give up something, as opposed to researchers coming into the community. So it's interesting, and hopefully we've given you some food for thought to take home with you tonight. Thank you very much.
Well, ladies and gentlemen, it is time to wrap up for the evening. I'm going to make a small presentation to our panel tonight because I think they've worked hard and deserve one. And I'll make a start. Thank you very much.
Thank you.
Thanks, Lisa. Thanks, Jan. Tak. And one for our facilitator, who's done a lot of hard work at the front of the room, so thank you, Owen, very much. Now, ladies and gentlemen, I hope you'll join us for our next Research Tuesday. In July, we'll be hearing from Professor Jodie Dodd about the impact of weight gain during pregnancy and what it means for our children. In the meantime, thank you and good night.